Have you ever reviewed a medical record and thought you captured everything, only to find out later that you missed a diagnosis? That doesn't always mean you don't know how to code. Sometimes the problem happens before you ever open the ICD-10-CM book. The real challenge is understanding what the provider is communicating. Hi, I'm Shay, and welcome to Coded Life with Shay, where we decode clinical documentation, risk adjustment, and the changing role of medical coders in healthcare. I've worked in risk adjustment coding, auditing, training, and now healthcare AI. And one of the things that I've learned is knowing the code set is only part of being a strong coder. You also have to understand the story behind the documentation. Let's take a look at a simple example. Type 2 diabetes mellitus, stable, continue current medications. Some coders would see the word stable and assume that the condition isn't important or that it shouldn't be coded because the patient isn't experiencing a complication. But stable does not mean resolved. It means the condition is currently controlled or unchanged. The provider identified the diabetes, evaluated its status, and continued the patient's treatment. That is an active condition being managed during the encounter. The coder's job is to review the complete record, follow the applicable guidelines, and determine the most accurate code supported by the documentation. Now, let's look at another common phrase. The patient is doing well. What does that actually mean? Doing well after surgery, doing well with diabetes, doing well on new medication, or doing well overall? The statement, the patient is doing well, cannot be interpreted in isolation. We have to connect it to the rest of the note. What condition was the provider discussing? What medical conditions were reviewed? Was the treatment continued? Was the condition assessed somewhere else in the note? Is the documentation connecting the statement to a specific diagnosis? This is where good coders sometimes miss codes. They may recognize every diagnosis term in the chart. They may know how to use the index and verify codes in the tabular list, but if they don't understand the context surrounding the provider's words, they can still miss what is happening clinically. The opposite can happen too. A coder may assume that a diagnosis is active simply because it appears in the past medical history or problem list, but the rest of the encounter may not show that the provider evaluated or addressed it, and the documentation may not support reporting it for that encounter. This is why coding requires more than finding diagnosis words. We have to understand timing, context, treatment, status, and the relationship between different parts of the medical record. This becomes especially important in risk adjustment. Chronic conditions may be mentioned in different ways throughout the record. The diagnosis may appear in the assessment while the medication may appear in the plan. Supporting information may be documented in the history of present illness, physical exam, lab results, or another section of the note. A strong risk adjustment coder knows how to review the entire encounter without making assumptions or coding beyond what the provider has documented. And this skill is becoming even more valuable as healthcare organizations begin using artificial intelligence and natural language processing to review medical records. AI can scan large volumes of documentation. It can identify diagnosis terms, medication, lab values, and possible relationships. It can suggest codes or flag conditions for review, but identifying a word is not the same as understanding what that word means in context. An AI system might find diabetes in the chart, but is the provider treating it as an active condition? Is it historical? Is there a documented complication? Does the suggested code match what the provider actually stated? These are questions that still require strong coding knowledge, documentation interpretation, and human judgment. That's why I don't believe the future is simply AI replacing medical coders. The future will require coders who can work with AI, evaluate its suggestions, identify errors, and explain why the documentation does or does not support a particular code. That starts with learning how to read the medical record as a complete clinical story. So the next time you miss a code, don't immediately assume you need to memorize more ICD-10 codes. Instead, go back and ask yourself, did I understand what the provider was actually saying? Did I review the entire note? Did I connect the assessment to the treatment plan? And did I code only what was supported documentation? Because becoming a stronger coder isn't only about learning more codes, it's about learning how to think through the documentation. So, if you want to learn more about clinical documentation, risk adjustment coding, and how AI is changing our profession, subscribe to Coded Life with Shay. And remember, don't just learn the code, learn the story behind it.